Good morning, everyone. I'm Eric McDonald, the County of San Diego's Chief Medical Officer, and we're here again this morning for a panel discussion on COVID-19 medical and health misinformation. I'm very pleased to be joined today by two local medical experts for this discussion. They are Dr. John Bradley. He is a board-certified pediatric infectious disease physician at Rady Children's Hospital, San Diego, and he's also on the faculty at UC San Diego. And Dr. Christian Ramers, he is the Chief of Population Health and the Director of Graduate Medical Education at the Family Health Centers of San Diego. He's board certified in internal medicine, infectious disease, and addiction medicine, as on the faculties at UC San Diego School of Medicine and SDSU School of Global Public Health. The focus today is on the Tuesday, January 11th COVID-19 update presented to the Board of Supervisors in San Diego County yesterday. And we will be focusing exclusively on misinformation related to medical and health issues. And this is not our first panel, but as I've mentioned in prior discussions, the county has established a link on our longstanding COVID-19 website, coronavirus-sd.com, that is meant to assist the public in evaluating information on COVID. If you go to the website, you'll see a banner marked Evaluating COVID-19 Information, and by clicking there, you can learn more about the different sources of incorrect information. There are links on the website to credible sources, some false claims that have been paired with facts, as well as some frequently asked questions. And when we're done this morning, this session will be posted on the website. Today's session is being simultaneously translated into Spanish. I'm trying to speak slow enough for our Spanish translators, and I want to thank them upfront for their contributions here. And you can access that by clicking on the translate button at the bottom of the screen, and it will be posted separately. So with that introduction, I'm going to start with Dr. Bradley. There were a couple of comments made by the public at the board meeting concerning children. The first was that since no child under 10 has died in San Diego from COVID, parents should not get their children vaccinated. I think it's worth saying that no child should die of a vaccine preventable disease, but death is not the only complication of SARS-CoV-2 infection. It can cause significant illness in kids. And I wonder if you can start by talking to us about what you're currently seeing at Rady's and why it's important for parents to have their children vaccinated for SARS-CoV-2.
Thank you, Eric. It's a great opportunity to answer that question. While kids in general do better with this infection, especially the Omicron infection, they do get sick from it. They're not dying, but they do get sick, and they do transmit the infection. And they can get MIS-C, this post-infectious inflammatory condition where the virus is gone, but 4 to 6 weeks later, the body all of a sudden thinks that the virus is still there and causes this huge inflammatory reaction. So first, the number of admissions that we see with COVID is fairly high, but most of those kids have other underlying conditions. So it's not COVID that's bringing them in. If they have chronic lung disease or heart disease or cancer, and they get a COVID infection and they get a fever and a bit of cough, it's enough for people to be concerned enough to bring them in. There's nobody that we have on oxygen, ventilators, that sort of thing. And if you're vaccinated, the chance that you'll get infected and be hospitalized is far less. So even though they're doing well, they can do better if they're immunized. A second really important reason is that if kids are immunized, then they won't be spreading COVID through their families. And I can't tell you how many people who I know work at Rady Children's Hospital, both healthcare workers and medical staff, whose kids who are not eligible for vaccines, many of them, and some who are but haven't gotten it yet, pick up COVID from their friends, and then they bring it home. And then the close exposure that you have even will overcome some of the immunity you get with vaccine and boosters. None of the adults that I know are getting very sick, but you'll test positive on the test, which means that you're off work. So to prevent spread in the community, so we can finally get this pandemic under control, it's important to immunize kids. And then I can talk more about the MISC later, but 1 in every 500 or 1,000 children who get COVID, even if it's mild, will end up 4 to 6 weeks later with fevers, muscle aches, fatigue, difficulty breathing, that sort of thing, which is the MISC inflammatory syndrome, and will come into the hospital for a short hospitalization as well and need to get treated with steroids and immune globulin. And we've just published with the CDC the fact that vaccine can prevent MISC.
Yeah, I think that's really important to emphasize, and it's also important to know about how kids contribute to transmission in the community. And it's worth commenting that transmission in San Diego right now, as we speak, is the highest it's ever been. The number of cases that are being diagnosed, it is likely that about 5% of San Diegans are actually actively infected with COVID right now. That's 1 out of every 20 people. And so the burden in the community is very, very high, and it's really due to this Omicron variant. And I know maybe I can ask Dr. Ramers about this. One of the questions that comes up is, gee, the Omicron variant is not as severe, so it's okay to be infected with it. And what would you say we know now about the Omicron variant that we didn't know perhaps a few weeks ago?
Thanks, Eric. I have a couple of slides, if I could maybe share those.
Oh gosh, yeah, please do.
Go through kind of what we know about Omicron, because there's been, the experience in South Africa to start. Give me just 1 second to get this up and running. Okay, so we have South Africa. We have really good data from the UK that got hit before us. And then we actually now have data from Southern California, just put on a preprint server. And the good news here is that South Africa made it through this Omicron wave in about 5 to 6 weeks. So we have a very incredibly rapid onset and then a real quick decline. What you're seeing here is South Africa as a whole on the left, with hospitalizations on top and deaths on the bottom. And then Gauteng province, kind of where this all started, on the right-hand side. And these numbers are lower than the Delta wave numbers, especially the death numbers here, which are kind of down here. And then the Gauteng province really, again, made it through in about 5 weeks. So we have that to look forward to. But South Africa is a very different place than the US. And this is just a population curve showing you the ages of the South African population on the left-hand side here, and the ages of the US population. We have a lot more people above age 65, above that orange line there. South Africa, a much younger population in general, and then a lot more comorbidities in the United States. And South Africa had a unique experience with COVID. There's actually 44% of the population that's vaccinated. And then more than half of people had evidence of prior infection. And most of that was recent with the Delta wave that just came in there. So you have a very different context, and it actually makes it quite difficult to determine just the virus itself. Is it worse in terms of causing more severe disease? This was recently published in JAMA, Journal of the American Medical Association, and it's a counting of the early phases of infection in the different waves in South Africa. So wave 1, 2, 3, and 4 corresponding to, I think, beta, alpha, delta, and then Omicron. And what we see with wave 4 is a lot of these outcomes are a lot less. So on the top here, you can see the percentage of patients admitted was less, 41% compared to in the high 60s or so. The number of people receiving oxygen therapy at the bottom is much lower, 17% compared to 70, 80%. Admission to the ICU is lower as well. But if you look a little more closely, the population is very different. So first of all, the age of people in this Omicron wave was way lower. 36 years was the median age compared to people in their 50s. The comorbidities was way lower, 23% being admitted with comorbidities versus 50 to 60%. Different vaccination status here, mostly unvaccinated people that are getting admitted in South Africa. As some people say that all the people that were very vulnerable have already died by the time this wave made it through. So assessing whether the Omicron variant is milder or not is very tricky in this type of population-based study. But it does look like the numbers are lower. So we see that a lower percentage of people are getting really sick and getting admitted. I'm going to skip through this one very quickly. We now have experience in the UK, which is a higher vaccination rate than the US. And what you see is a real decoupling of this huge explosion of cases in the UK, and just really a small increase in deaths. And of course, that's a lagging indicator, but that also indicates that we have a lower severity of disease. And the UK government has done a very nice study very rapidly. This was published over the New Year's break here, but we absolutely know for sure that Omicron is a lot more contagious. So they say it's between 2 and 3 times more contagious than Delta. And we already know that Delta is an incredibly contagious virus. They did a very rapid analysis of 500,000 Omicron and 500,000 Delta cases just to compare them side by side and see what the hospitalization rates look like. And it was actually about half the risk to be hospitalized compared with that of Delta. And if you went to the ER, your risk of actually being admitted was about 1/3. So for whatever reason, that does actually look like Omicron is a relatively more mild condition. I'm going to pause and make a point here that if it is half the hospitalization rate or half the death rate, but you have 5 times as many infections, the numbers actually continue to go up. And that's really why we're seeing what we're seeing in the United States. It's just simple math. Half the death rate, but 5 times the amount of infections gives you more deaths. There's probably a biological reason for this. These are animal studies as compiled by our local Eric Topol in a table on his Twitter page here, showing that if you do a mouse model or a hamster model and you infect them with different versions of the virus, it looks like Omicron causes less deep lung disease and has a lot more trouble replicating deeper in the lung tissue. So you have basic science data suggesting that. And then finally, in Southern California, this was just put on a preprint server yesterday. This is from Southern California Kaiser. They did a retrospective analysis of end of November and into December and used this trick called S-gene target failure, which is a rapid way to identify whether people are Omicron or not. And they compared 52,000 Omicron cases to 16,000 Delta cases. And the rate of admission was about 0.5% in the Omicron and 1.3% in the Delta patients. So again, looking like it's about half as likely to put people in the hospital. Again, that might be because of prior experience, prior immunity, but it also does look like it's a little bit more mild. They had nobody with the Omicron variant, at least in this sample, that was on a ventilator, and they had 11 in this sample that were on a ventilator with Delta. So in terms of severity, it does actually look like there is a little more severity there with Delta compared to Omicron. And then just 1 or 2 more slides here. Also great work from the UK. What does vaccine do to Omicron variant versus Delta variant? And what we see here, this is very interesting to me. You have Omicron here, and you have no vaccination, and then 1 dose, 2 doses, 3 doses going down the column here. And the Delta here, the benefit of getting that booster for Delta is pretty marginal. You're getting just a little bit more protection going from this is a hazard ratio. So it's sort of a 82% protection to an 85% protection. But the benefit in Omicron of going from 2 doses to 3 doses is much, much bigger. You get a much better boost from that boost because the virus has sort of changed the way it looks. And that's also shown in the bottom table, resulting in basically a vaccine efficacy for the Omicron variant with the 3 doses of about 88%, protecting against hospitalization, whereas just 2 doses is only 52%. So that booster becomes incredibly valuable. And to show you this in visual form, this is the Moderna vaccine, how it performs. You know, you get 6 months out from that 2nd dose of Moderna, and you're really not getting very protected at all. But then if you get a booster, you get a nice increase back to that sort of 70 to 80% protection in terms of hospitalization. So I'll just finish with one final figure. You know, milder or not, this is what's happening in the US. Cases are exploding. Hospitalizations are actually now the highest they've ever been in the United States. So because of the math and the way it works out, even though it's a less severe variant, possibly, we have so much of it around that our hospitals are really, really in trouble.
Yeah, thanks for that. That's a really important. So the big take-home message is, if you haven't been boosted and you're eligible, you should. If you haven't been vaccinated in the first place, you should get vaccinated, because this is all data that shows that the vaccine is efficacious. I think that's really quite critical. And maybe tossing it back to Dr. Bradley, I know one of the comments that was made yesterday was that the vaccine isn't safe, that it's killing kids, and we just know that that's not true. But I wonder if you can just talk about how you're, again, counseling families about getting the vaccine.
The vaccine is safe. Let's start off the conversation that way. There were indeed limited numbers of children who were vaccinated for which we had 2-month follow-up safety data. when the vaccine first got its emergency use authorization. So we're in an emergency, and even though kids do better, there was a clear benefit to the vaccine, as I shared with you, that was presented by CDC to the Advisory Committee on Immunization Practices. So immunization is critical in kids. Can we go back to your original question? Can you restate that? I don't want to lose track and focus.
No, it's about how you're counseling parents on
Yes.
on getting the vaccine, and I think that's you've made the case that it's good and safe. I think one of the things that people in the community who are making comments that are inappropriate at the Board of Supervisors meeting is they basically significantly understate the severity of COVID-19
Yes.
In terms of a disease, and then they significantly overstate the risk of the vaccine. That's their modus operandi, and I think that what you're saying to equilibrate about why it's safe and effective to get the vaccine is important.
And to give you an update, there are now in the United States 7 million doses of Pfizer vaccine that have been given to children in the 5 to 12-year age group. So although we had a few thousand data points when the vaccine was first authorized, now that we're months into authorization, there's widespread immunization. 7 million kids have gotten it. And the safety pattern that made us reassured that the vaccine was a safe one has continued through with 7 million. So anyone that says, oh, I'm going to wait, you don't need to wait any longer. The data, massive data from children immunized in the United States, tracked by our healthcare system, is now in.
And Dr. Ramsey, did you have a comment? You look like you were going to say something, but if not, I have another question.
Yeah, just to add on that, the CDC through the MMWR journal is publishing real-time data at all times. And there was just another recent publication just about breakthrough cases, because we know they happen with this Omicron variant. There will be people that are fully vaccinated or completely up to date with 3 doses and getting their booster and still getting COVID, but it's incredibly mild. And the only people that are suffering severe consequences tend to have multiple other risk factors or be immunocompromised. And this, I was just trying to bring up the numbers here. I think it's a 0.003% risk of death in a person who's fully vaccinated if they get COVID, which is just infinitesimal. And then those that are having trouble, on average, or 75% of them had 4 additional comorbidities. So it's a very, very small proportion of the vaccinated population that's really having any trouble with this at all.
You know, I'm really glad you brought that up, because this is a classic misinformation thing that happened yesterday. Several speakers, unfortunately, yesterday made this comment. That study actually shows how well vaccines work. And that snippet that 78% of the individuals who were fully vaccinated died from COVID with that very, very low percentage. And those specific people had 4 or more comorbidities. Unfortunately, what's happened is people have taken that soundbite and applied that to everyone who's died of COVID during the entire pandemic. And it's just not true. It's not true. And in fact, if you go back to the CDC director that's being quoted in that very small snippet, she's referring to this study of fully vaccinated people, not everybody in the entire group across the United States who's died of COVID. And I think that's extremely important. It's been, unfortunately, repeated inappropriately by local media. And what I would do is ask people to look at our own COVID Watch reports, which actually show what the common underlying conditions are for COVID-associated deaths in San Diego. The most common is hypertension, which is very common in adults. And this is not true of the deaths in San Diego or nationally, that 75 or to 78% of them had this many comorbidities. And I wanted to make sure I emphasize that point.
Yeah, and I'll just add an underlying point there, is that there are people that are very healthy and relatively young that still have a hard time with COVID. It's very unpredictable. You know, our immune systems are essentially all different from each other. And it's a shuffling of the deck of cards that you get genetically from your parents and the other coronaviruses that you've encountered in your life, and you never know. I hear these really tragic anecdotes of young people, fathers and mothers who are dead in their 30s or 40s, who are in great shape. You just never really know. It's, of course, a lower risk, but you don't know in terms of the comorbidities. And then also, comorbidities matter a lot. That's why I said South Africa and the US are going to be very different. We are not the healthiest country in terms of industrialized countries, with a lot more diabetes and obesity and hypertension. So the message that I think has been underemphasized, and some of the speakers have called this out, I think appropriately, we should also be telling people to get healthy and lose weight. And there's things that you can do and modify to decrease your risk of dying of COVID. Great chance to talk about all that.
I just want to share a perspective from pediatrics, because we immunize kids, as you all know, to try and keep them healthy. For most of the vaccines we use, the vaccines are used to allow children, if they're exposed to the bacteria or the virus, to have modified non-serious disease. So the pediatricians don't really expect perfect vaccines to prevent all disease. And there's a lot of work in the influenza area. How good are vaccines for preventing infection at all, preventing a hospital visit, preventing death? So there's all different ways to look at vaccines. So the fact that while the vaccines are good, they're not perfect, and you can get a breakthrough infection, to us, that's absolutely no surprise. But we're not dying. We're not going into the hospital. So this vaccine is doing exactly what we want it to. And the people that say, well, it's breakthrough, that's not working, that's completely taking this information and standing it on its head. The other bit of information that's recently published out of Israel has to do with people who are vaccinated and have also had COVID. So, so whether you got COVID and then were vaccinated, or the other way around, you got vaccinated and then got COVID, if you look at antibody titers and those that had both, they're sky high, just sky high. So the protection you get from the vaccine helps you with your COVID infection in making you more protected for the virus that's continuing to circulate and potentially other strains of COVID that may emerge later on.
No, and I really appreciate you making that point too. I think one other thing I'd like to do, since Dr. Ramers actually did a nice job talking about math, how math matters. Another piece of math that matters is, there were some speakers yesterday that said, gee, look, there are almost as many cases of people who are breakthrough that of people who have COVID, been diagnosed as confirmed cases who've had vaccinations versus those who've not. Actually, still the number who have not are outnumbering those who are fully vaccinated. But the important thing is, again, math. It's about rates. More people in San Diego are fully vaccinated than not. And so, people who have been buying gas recently could probably know what rates mean. So if I give you a 1 gallon tank of gas for $5 and then give you another one that's 4 gallons of gas for $5, you'd pick the 4 gallon tank every time because it's cheaper, okay? And yeah, they both cost the same, but there's 4 times as much gas over here. And that's why it's important to not just look at the numbers, but to look at the rates. And actually, Dr. Wooten did a wonderful job of presenting that. We've been reporting on that week after week in terms of cases, hospitalizations, and deaths. And it's multiple times higher for those who are not fully vaccinated compared to those who are vaccinated. And it is even better for those who are boosted. And we haven't been publishing that information, but we will soon so that we can show that. But certainly, of the folks who are in the hospital now, there are 4 times as many people who are unvaccinated compared to vaccinated. And the number of people who are vaccinated and boosted who are actually hospitalized now in San Diego is well under 5% of the cases. And those are people, as we talked about before, who have multiple medical problems and probably have some immune deficiencies. So again, I think it's important to just not look at numbers, but to look at rates, and which is why rates are important.
Yeah, and Erica, one other comment just about immunodeficiency. It's a term that's thrown around a lot, but there are, I'd say, 3 to 4% of the population that really are not going to respond very well to a vaccine because of a medical condition, because of having cancer, because of chemotherapy or medicines that they're taking for other conditions. And those people do get lumped in the vaccinated group. And I can't remember the number off the top of my head, but a significant proportion of serious outcomes in vaccinated people is actually in those that are immunocompromised. And so the vaccine really isn't able to do what it needs to do. And this is just comes down to this basic fundamental principle that we need to protect the most vulnerable amongst us. You know, you see somebody walking on the street, you don't know if their parent or spouse or child has an immunocompromising condition. And so the idea of wearing a mask, not just to protect myself, but to protect my fellow San Diegans around me that may have no benefit from the vaccine at all and be just as vulnerable as they were in April of 2020. You know, that's a major concept that I think is lost on a lot of people, that breakthrough infections in vaccinated people, a lot of them are actually in immunocompromised people that are not going to really respond to the vaccine.
And it's so important now, again, because the amount of virus that is circulating in the community is so high, and we really do need to take those precautions immediately. So if we, I cannot emphasize that enough. You know, one other just quick point that came up yesterday that's come up before. We've talked about the therapy and what works and doesn't work early in COVID, and somebody just simply played a tape for 2 minutes of essentially misinformation about what does and does not work early for infection. And so if I could just ask you, Dr. Reimers, what's new with what works and what is essentially ineffective for early treatment for COVID?
Yeah, let me first address vitamins. So, you know, vitamin D, vitamin C, these are things that the body needs to fight infections and to do a lot of normal processes. And if somebody is grossly deficient in these things, then yes, they're going to actually have a more severe outcome. So being replete or taking vitamins on a regular ongoing basis, which most people can get from a good healthy diet actually, is a good idea. Using vitamins as therapy doesn't really work. So there's been plenty of studies looking at, you know, high dose vitamin C, high dose vitamin D. It just doesn't work as a therapy. It's almost too late by that point. So if you're going to take vitamins, take them now. Don't reach for them when you're sick with COVID. That's fine. What about other repurposed drugs that we sort of just pull off the shelf that are being used for something else? And like maybe we can have a big shortcut and not have to develop new drugs for COVID. Of course, hydroxychloroquine doesn't work. Plenty of data showing that that's true. Ivermectin, I will say that the data is just very weak and mixed and controversial, but better data is coming very soon. And there are very properly run randomized controlled trials that are going to be reported out soon for ivermectin. It's hard to believe that it's a very efficacious drug when you have some well-conducted trials out there showing it's exactly the same as placebo. I mean, a drug has to really not be very good if you have a curve that looks exactly the same as placebo. How does that happen? Well, it happens if the drug is not very potent or not very powerful. So that's why ivermectin has not been endorsed by any guideline committee to this point. That may change if better data comes out. We are continuously iterating this and looking for better data. The one I want to comment on specifically is fluvoxamine. So this is a repurposed drug that actually has 2 fairly well-conducted studies and a third that's coming out soon that do show a little bit of a benefit. There's some discussion about whether the studies were properly conducted, but it's to the point where an infectious disease doctor from Minnesota actually filled out an application to the FDA to try to get authorization for fluvoxamine. So we'll see about that one. That's sort of on the back burner. But what we have now are approved therapies that are actually highly effective. They're in scarce supply, so that's an issue. I will acknowledge that, and we have to triage who gets them. But the monoclonal antibodies, sotrovimab being the one that works against all variants, highly effective, 88% reduction in hospitalization. And we're now getting more in our toolkit. So we have Paxlovid, an oral agent. I got also about 88% effective at reducing hospitalization. Remdesivir, if you give it IV early, is very effective at preventing hospitalization. And then molnupiravir, a little bit less so. So that's kind of lower down on the tier. But we're talking 80% reduction, except for molnupiravir, about 30% reduction. These all need to be given early because they're antiviral agents that will target the viral replication phase, which is really the first week to 10 days of infection.
Eric, can I add on
Please
to
do.
Christian's comment? Because repurposed drugs is something we all really want, and no one's stepping on repurposed drugs. I've been involved in drug development with antibiotics for 40 years, and you always look at risks and benefits. And we know from test tubes and experimental animals what dose you need of a drug in order to kill the bacteria or shut down the virus. And if the amount of drug in a test tube or in an animal is far higher than can be tolerated by a person, nobody goes ahead and investigates that drug. The toxicity of the higher dose that might be effective just isn't worth it. You're sicker with the drug than you are from the disease. And as we look at ivermectin, and I've seen the data that Christian is referring to, in a test tube, it's got some activity, but the amount of ivermectin you need to take is so much to get a possible effect. It will cause you tremendous injury. So we're looking for drugs that are both effective and safe, and those are the ones that we'll recommend. And those all go through an FDA approval process. Most of those will be presented publicly to the FDA by committees so that everyone in the United States can see risks and benefits. And that's a huge part of the decision-making process. And thank you, Christian, for bringing those up.
Actually, I have hit the newer targets and actually some of the repetitive ones. There were some other things that were brought up, for example, misquoting the data from the VAERS database as causal in terms of the effects of the vaccine, that sort of thing. We've actually talked about that in prior panels, and I'm going to refer folks to those. Same thing about the tests that are used. We've had some extensive discussions about tests, and I'll refer to prior discussions on that also. But before I close, I wanted to give both of you a chance to say if there's something that you're hearing from patients or really in terms of discussions in the community that we haven't talked about that you think deserves some emphasis on this panel in terms of misinformation, just wanted to give you a chance to comment on that. So Dr. Bradley, we've covered a lot of territory already, but anything that you wanted to add?
Just that, they're studying the vaccine for the younger kids, 2 to 5 year, and then it will go down to 6 months of age. So we're continually looking at that. And I just want everyone to know that when the data are presented at the FDA and at the CDC, it's public information. And everyone who's listening to this can actually dial in, put in your questions. So on a national level, with the experts who are actually collecting data on safety, you can find out at the very beginning the most accurate information about vaccines and drugs. You don't have to wait until there's a social media post that you don't know if you'll be able to trust or not. So it's a very transparent process, and I'm very fortunate and in awe that so much time and effort has been put into the safety of these products. Thanks.
Thanks, Dr. Bradley. Dr. Ramers, I'll give you the last word.
Thanks. Nothing really targeted at misinformation, but I'd like to just kind of say some things that I think deserve emphasis. The first I mentioned before is the value of a booster has gone way up. The booster shot, when it first came out, there was some debate, is it really needed? It absolutely is. It's gotten to be a much more high value proposition for people to get their booster. So that's really the best way people can protect themselves. I don't think we talk enough about human behavior and, masks. We know the data on masks, vaccines, we know the data on vaccines, but people are being asked to make complicated risk decisions, multiple times a day. And I'd say for the next couple of weeks, maybe it's not the right time to go out to eat every night or go to the movie theater or go shopping. And the reason is because of what you stated, Dr. McDonald, that if 5% of people in the county at one time are infectious, you go to a grocery store with 40, 50 people in it, that's a lot of people that are, whether they know it or not, able to spread the disease. So it's just a very, very high risk time at this point. Having seen a lot of patients with long COVID who didn't really have very severe cases, I wouldn't wish this on anybody. This is a terrible outcome that has nothing to do with hospitalization or death. So just be careful, make good decisions. And that involves getting boosted if you're eligible. And then leveling up your mask, we talk about a lot. So N95 masks, they're now plentiful if you can get your hands on it, and they're very comfortable for people to wear out there in the community. And just, let's just lay low for a couple of weeks. This is going to pass. I'm encouraged by the UK that's had a declining rate for the last 6 days, actually, of infections. And then South Africa, which got through this entire wave in about 4 to 6 weeks. This is going to recede as all surges do, but just kind of lay low for a couple of weeks and we'll probably all be okay.
Yeah, I think that's a wonderful note to end on. And although we talk about misinformation here, it's really important to talk about the fact that most San Diegans are doing what needs to be done. And we really appreciate that and understand that that is influencing your life and is a sacrifice, but it's not for naught. It's to protect our healthcare system, to protect our fellow San Diegans. And we really appreciate everything that's being done. Again, also a shout out to both of you and the organizations that you work for, your staff, the direct frontline healthcare workers, and everyone who's supporting you to deliver healthcare to our community. I want to thank you on behalf of San Diegans. Also want to thank our two translators. Hopefully we weren't speaking too rapidly on this with medical terms throwing out. You guys, I'm sure, have done a wonderful job. So Barbara and Isabel, thank you so much. Also, thank you to the county staff who put this together. And we will end this session now. And thank you again for your participation.